Good morning, everyone. Thank you, Dr. Chu. So the idea is to try to know how do we do step by step to correct our sagittal plane. And when I started this talk, I kind of thought, well, what are the steps that I'm taking every time I see a patient? And I think this is important because at every step, at every milestone, there's something that can go wrong and we can go the other way. You can see when you have your patient clinical presentation and then you will ask for X-rays, MRIs, CT scans, and you need to get all the information so you can get a good analysis, a good diagnosis. And when you have the correct diagnosis, then, and only then, you can apply or indicate the correct treatment. If you don't understand what's going on, then you cannot treat it, or your indication for treatment will be wrong, and that will end with a poor outcome. Of course, it's not enough to understand what's going on and to indicate the right treatment. You have to execute that treatment correctly. And that's another way where it can go wrong, although you understood what was going on. And we all know that despite all this, even when we understand, when we indicate the right surgery and when we execute it well, sometimes the results are less than we hoped for. I think the most important thing when talking about sagittal plane is understanding where we're going, what our goal is. And I'm glad that Shane talked about the Russelli classification, because I think it's now accepted and proven in the literature that we are not all the same and that we cannot measure all the same for everybody. So our lordosis cannot be fixed to L1 S1 because we're all different. And as you can see, and then Shane also underlined, we have different types of backs with a different shape of lordosis. And this means that the apex of the lordosis is not in the same place, and that the length and the number of vertebrae that are included in that lordosis is not the same. So if you measure everybody at type 4 and at type 1 from L1 to S1, you will actually get misguided by that measurement, and then get misguided in your treatment. The goals have to be clear. And if our goals are not clear, then sometimes we end up in a place where we don't want to be, and we end up having a complication. So this is the key message for me in this talk. The shape is as important as the magnitude of the lordosis. And we have proven recently in a multicentric study that I will show you that the apex, where you place the apex of your lordosis, is the greatest factor to prevent PJK. So if we keep on doing our corrections in L2, L3, we are putting our apex, the apex of our lordosis, too high. And so we're lengthening our lordosis. And by doing that, we are reducing the space that we give our kyphosis, and that's why we get proximal junctional kyphosis. So we have to keep that in mind because we are placing the apex of our lordosis too high. In type 1 and type 2, our lordosis is short, so the apex has to be very low. It has to be below L4. And this is a study that was done, recently published. It's a multicentric study done in France, where we found that restoring the apex of the lordosis according to the PI, so according to the shape of the spine, was the best predictive factor to avoid PJK. So we have to stop with some simple rules that actually are oversimplifying the problem. And we cannot measure everybody the same way. We cannot measure from L1 to S1 every lordosis because the lordoses are different. So to further explain this, I will show you this patient. This is a 72-year-old that came to me with a three-dimensional problem. So he has, of course, a decompensation of the sagittal plane with a global kyphosis and a coronal plane. A coronal problem with a coronal imbalance. Now, what's interesting is to see what's going on and to try to understand where the pathology is. So we have a lumbosacral kyphosis, but look at what's going on here. He has a straight back, so he's low-dosing his thoracic spine to compensate for this. Now, is this stiff? Is this rigid? Do we have to act that? Is that a compensatory mechanism that is part of the deformity, or is it just compensated and we'll go back to normal if we don't touch it and if we leave it out of our treatment? And we have to include this in our reasoning. We have to include also the deformity on the frontal plane if we're going to do something for this. So how can we do, what are the tools that we have today to be able to deal with this kind of problem? Well, we ask, of course, for all the information. We need all the studies to really understand what's going on. And here we see that, for example, this segment between L2 and L4 is totally fused. And he has air in the discs in the lumbosacral area, so that is something that we can use for our correction, and is in the right place. We want to increase our lordosis in the lower arch. We want to put our apex low. So this is something that we can use. But we have to understand that there is also a fusion here, and if we want to do something there, then we'll probably have to do an osteotomy. So these are all things that we have now. We have all the information, and now we can plan what we're going to do. And there are many softwares. I'm using one of them, which is Cheops. And this software allows you to have a three-dimensional planning. You can rotate the spine and see what's going on in the frontal plane, in the sagittal plane, and it will give you not only the pelvic incidence, of course, and the tilt, but it will also give you the type and what the problem is. So you see, you have the sacral slope, you have the ratio, so this is like the SVA, pretty much. And you see the lordosis, and you see the lumbosacral lordosis down here. So you start by correcting the frontal plane, and then you decide what you want to do and where you want to put your correction. So you correct your pelvic tilt, and then you say, well, what do I have to do? I need more lordosis. Where do I need it? I need it in L4, but this, I need how much? So I need to get this back to the green area here, so I'm deciding to do a PSO of L4. Can I get all the correction there? Do I have to get all the correction there? Remember that there was a mobile disc in L5 as one, so maybe I can take advantage of that and do some correction with an ALIF cage or whatever you want to use, as Smith-Peterson osteotomy there. And you can get the correction and simulate what you're going to do. What we're not able to predict is what will happen in the areas that we're not going to include in our fusions. And we don't know exactly how the spine is going to react. And this today is some sort of educated guess that we're doing to try to prevent the decompensations and the problems that we have with proximal junctional kyphosis, for example. We have to keep in mind that planning is exactly and very important, but that sometimes the reality is not what we planned for. And we have to be prepared to alter, modify, change our plan if something doesn't go the way we want. Very important also, we need to verify and control what we do. So we need intraoperative x-rays and measurements to know if what we planned for and what we thought we were doing is effectively what we are doing. And you can see that you can control your corrections and even do the measurements that you need to see if you got what you planned for. So the idea is to do what you plan for, and if you're coherent with your plan, if you're consistent, then you will get a good result. I did a PSO of L4, an ALIF here, and I have a harmonious balance with the lordosis and the apex of the lordosis where it should be. This is 1 year, 9 months, post-op. And you see, I didn't go up the thoracic spine, and that allowed a little bit of kyphosing of the spine, but not too much because my lordosis is in the right place with a harmonious correction. So that's pretty much how I correct the sagittal balance step by step. Thank you very much.